So first, we have Dr. Cornelius Dyke from Sanford Health.
Should work.
Progress your slides with this,
Okay.
or even with.
That's fine.
Okay.
Perfect. Thank you.
All right.
Thank you. It's a pleasure to be here. And I guess first I'd like to thank Dr. Schwartz and the entire TRANSCEND team. I know Savannah and I have been emailing a lot, so thank you for that and all for your help. But it's very exciting to be here. This is an exciting award, and our team is excited to progress with our project. And I'd like to hopefully share that today. Our project is entitled AI-Powered Risk Prediction to Improve Outcomes in TAVR, and I'll tell you what TAVR is in a minute. I do want to emphasize the collaborative nature of this grant, and the people here, our research team, Dr. Kim, future Dr. Rahana, Jung Wook is my mentor at TRANSCEND, and his counsel has been invaluable, and then the research institutions that I work for. I am the professor of surgery and the chair of surgery at the University of North Dakota, and also a cardiothoracic surgeon at Sanford Health. So I have two of those institutions, but I don't have any computing experience, so the School of Electrical Engineering and Computer Science is critical. What we're talking about in terms of TAVR is valve replacement, transcatheter aortic valve replacement. So we start with the aortic valve, and anatomy is always a good place to start. The aortic valve lies between the left ventricle and the aorta for unidirectional blood flow. In the normal state, opens widely, closes efficiently, doesn't leak, and there's no obstruction to flow, no gradients across it. But over time, with a diseased valve, you can see you can have very heavily diseased stenotic valves, and that's the pathophysiology that we're treating today, aortic stenosis. That's the disease process. Unfortunately, aortic stenosis is very common. It's very common in the elderly, and it's very common in North Dakota. You can see that the prevalence rises with age, such that by 80, almost 10% of the general population has aortic stenosis. The thing that's bad about it is when you get it, it's latent for a long time, even decades, but then when symptoms start, bad things start to happen, and this shoulder here is quite steep, so that within years, bad things such as stroke, death, MI occur. This latency period, as I said, could be bad and look prolonged, and then when it's severe, that's when we want to intervene. Before 2012, which is not that long ago, surgery was the only way to do it. I've put in a lot of surgical aortic valves. That was the way to do it. Starting in the 60s, we would put in mechanical or bioprosthetic valves, open heart surgery, 3-4 hours of surgery, 4 or 5 weeks of recovery, and there was some rehabilitation and some, it's a traumatic event. Even surgeons will admit that. And then this crazy Frenchman, Dr. Cribier, in 2002, did the very first in-human aortic valve replacement with a catheter through the groin. And everyone thought this was crazy. The valve was going to shatter, it'll shower emboli, cause strokes, all these bad things will happen. Well, it didn't. And in about 10 years since the first implant and FDA approval in 2012, many, many studies came out. First in the non-operative patient, then in the high-risk patient, and then subsequently moderate, low risk, and now even asymptomatic patients. So it's tremendously important and has revolutionized. And this is Nobel Prize-winning stuff. Unfortunately, Dr. Cribier passed away, but otherwise I'm convinced he would have received the Nobel Prize for Medicine. If you look at how it's affected us in the United States since 2012, and we started this at Sanford, I was on the team that did the first ones there, there's been a 44% decline in surgical valves, and in patients over 80, nobody's really getting a surgical valve, 96% decline. Even patients who are younger, by far, are getting transcatheter aortic valve replacements, or TAVR, is what we call it. About 140,000 are going to be done in 22, and almost 200,000 a year. This is in the United States. To do this, initially, we would open the groin and use the femoral vessels. Now we do everything percutaneously, so there's just a little poke hole in each groin. And we put it through the femoral vessels. And that's the basis of what we're doing here, because this femoral vasculature, peripheral vasculature, is what can be injured. It is one of the, shall I say, weak points of the procedure, and it's the focus of our grant. Catheter valve does a good thing, but vascular complications occur at almost, depending on who's doing it and how you measure it, 6 to 10% of the time. So this is what we did. We looked at 2,000, over a 10-year period, 1,300 patients, had about a 5.8%, so we were pretty good. We were right in there with our complication rates. And this is the data set that the TRANSCEND grant is based on. What we did resulted in, I think, a nice paper published last year where we basically defined risk factors, vascular risk factors, that predicted or determined peripheral vascular complications. We concluded that a robust evaluation provided better framework than just looking at it and subjectively saying, oh, gee, that looks like, it's tortuous, or there's calcium there, or that might be a difficult one. It took time. We had a researcher, Dr. Rowe, one of our residents, who took a year off. Each analysis of the CT would take 30, 45 minutes. He counted branches. He counted the pattern of calcification. He calculated the tortuosity. Incredibly detailed CT analysis required to do this. So then we were thinking, well, gee, we've heard about this AI stuff that can make hard things easy. Let's, maybe we can do that. And certainly AI is used in imaging, and we think it can be used here. So our goal and the purpose of the TRANSCEND grant, pilot grant, is to develop an AI model to automate this CTA interpretation. And we want to validate, once we create the model, prospectively in our patients that we're going to be doing valve replacements in the future. That 1,300 plus data of patients that are already analyzed, and that's key, that's an incredibly rich data stream that's the basis of this grant. Because it's already data, these CTs have already been read, they've already been analyzed by experts. They create this data set, and each CT, each of these patients, their CTs are quite large. We're approaching 750,000 plus individual images that we can use for analysis. Now, we only have 80 patients who had a vascular complication. That's good, right? That's a good thing. So we do have some statistical modeling and things that we can do to increase that size and help us with our predictive abilities. And I know a lot about aortic valve replacement, and this is where our collaboration is key. So with Dr. Kim at the School of Electrical Engineering and Computer Science, our PhD student, future Dr. Rahana, and with Dr. Her, my mentor with TRANSCEND, we're going to come up with this model, an algorithm, using computational neural networking for vascular analysis. And we're going to have that imaging, AI imaging tools are available. And so we're going to start with one that's available and then train it basically. And I apologize to Dr. Her for simplifying this, but we're going to train it to identify the vasculature, identify regions of risk, and then go ahead and create our model. So we're going to take a known computational neural network, faster RCNN. We're going to identify areas of risks and regional objects of interest in the vessel that we think might be predictive. We're going to bundle these, layer these, stack them, and then the key part, we're going to connect them with our clinical data. Remember, these are already identified, we already have been read. We're going to connect them with our tabular data, our clinical data, create our network through this black box that Dr. Kim and Dr. Rahana are going to create. And then we're going to create our model. And that model then we can test with future patients. We are going to do some cool things. I like Dr. Schwartz's Hercules, because we're going to use a similar, we're going to smote some of this data and create oversampling so that we can identify our patients or our images and our predictors so that we can create our model with increased precision. We're going to then validate this in 100 prospective patients. That's not a lot to do it, but it's a proof of concept. It's not a hypothesis-defining thing, but it's, I think, a proof of concept. And this is our timeline. If we can, in the first 6 months, create our model, the second six months, get our patients enrolled, we should be in good shape. So in conclusion, we're going to take this rich data set that we've already created, create our AI machine learning model, and then test it, hopefully making TAVR safer for patients who have this procedure here and elsewhere. The other nice thing, potentially, this could be generalizable to other procedures that are done, aneurysm repair, peripheral vascular work. So there's a lot of potential other applications that could occur. So with that, I'll stop. I hope I'm at my time. I haven't been tossed yet, so I'll be glad to take any questions. And thank you for the privilege of presenting.
Thank you. That was really wonderful. It's inspiring. It has direct impact on patients, and it can help develop the science. And it seems like you have a lot of the bases covered. One of them is the AI for image analysis. And then it sounds like you're taking the image analysis and entering it into multidimensional models for prediction, which is an entirely different thing with AI, which is great. And then I'm wondering, you have a database and registry here, it sounds like, or are you thinking of forming one from the group that you have? And then finally, you have a sample size that's constrained by who you have here. Is there a possibility that you can help leverage and train your models with databases that are being collected at other universities so that you can have sort of baseline information for the models that you develop and kind of leapfrog ahead and have more power in your models?
Yeah, thank you for those comments. Our data set exists through Sanford Health. These are images that exist there. We are using them, so they're not at UND. We'll be using them with a HIPAA-compliant manner to de-identify and then analyze those data, basically using it in the Google Cloud. In terms of other data sets, there are commercially available data sets that just aren't as robust or as good. Anytime collaborating with institutions about patient data can become difficult. One of the advantages, though, of being with Sanford Health is that we do have a very large network, and it is possible that we could go outside of Sanford Fargo, but we could go throughout Sanford Enterprise, and that would bring forth many more patients. So we do have that ability. Our initial 100-patient validation will be the precursor to that, to show that we can use it prospectively, and then potentially, I'm thinking this would be the great opportunity enterprise-wide for a larger, full, bigger grant opportunity.
Well, that was really very, very interesting, but I have a peripheral question. In your introduction, you said that for most of the patients, the development of the disease takes a long time, and then there's a precipitous fall. Have you given thought to developing some sort of algorithm to be able to identify these patients much, much earlier in the disease process?
Absolutely. It's a little bit outside this realm. CT obviously does carry measurable risk of radiation, et cetera. Echocardiography is the gold standard for screening, and echocardiographic screening is commonplace for aortic stenosis.
So part of the problem then for North Dakota at least is that many of the citizens of the state don't have access to those kinds of diagnostic procedures.
Great point, and that's the actually topic of the cardiovascular fellowship with my colleague Dr. Haldis on this project, who is bringing, the good thing about echocardiography is it's mobile. You can put it in a truck, load it up, take it anywhere, and that's the subject of additional investigation to bringing it to disadvantaged areas in the state who don't have access. Easy, portable, painless, no radiation, and it's an excellent screen. So definitely. The best screen, and I'll tell you to talk to your primary care physicians, is put a stethoscope on the chest and listen for a heart murmur. And that's the best screen.
Sounds like another pilot project.
There you go.
A quick follow-up question. How are you modeling in medical management in terms of outcomes? Because these people are getting all kinds of cardiac drugs, probably.
So these 1,389 patients, we actually, and it's in our complete manuscript, have been followed out, and we have Kaplan-Meier survival, we have clinical outcomes as defined by the TAVS societies, stroke, MI, rehospitalization, death, bleeding. And so those data, we already exist. So that's one of the robust and rich natures of this data set. We know what happens to these patients. Going further, the subsequent grants, clinical follow-up will be an important part of that for sure.
Thank you so much, Dr. Dyke.
Thank you
Let's
very
give
much.
another round of applause.